Most short-acting beta agonists come as a metered dose inhaler. And so it's very important when we're using a metered dose inhaler that we assess a patient's technique, because even with proper technique, this is a slightly poor delivery device, and only about 25% of the medicine will typically reach into the areas of the lungs where it matters the most. And so at every opportunity, whether you're dispensing a medication or following a patient for their respiratory management, you should assess their technique. Because what we find when we look at barriers to medication adherence is that poor technique tends to be one of the reasons why we see medications titrated up when there's really no necessity to titrate that medicine up. And instead, if proper technique was demonstrated by the patient, they would have been maintained on that original medication. For metered dose inhalers, each of them is going to have different types of priming guidelines when a patient first picks up the inhaler. And so in order to prime the metered dose inhaler, you typically do need to shake up each of these inhalers. There are a few where you don't need to shake, but in order to just avoid confusion for patients, it's a good idea just to teach them always to shake up the inhaler. And when you're initially using these medications, you will normally let out a few priming puffs from that inhaler. So if you notice that first puff, it didn't come out as strong as it should have compared to that second. And so that's just kind of priming that inhaler so that each time that patient takes the inhaler, they're getting the proper dose. Now, metered dose inhalers have been reformulated, and they now contain that CFC propellants. And with the CFC propellants, when you look at the plume, okay, the plume of a CFC propellant is a widely dispersed plume. And so with these types of inhalers, it's very important that the patient either directly puts the inhaler in their mouth or that they use some sort of a spacer or holding chamber device when using the inhaler. And this makes sure that they're getting that proper dose of medication. Prior to the CFC propellant, it was suggested that you could use a two-finger method. However, because of that plume distribution, if a patient uses the two-finger method, they are not going to receive the right amount of medication. So the best way to use these is either directly in the mouth or with a spacer or holding chamber device. Breathing with these devices is extremely important. We want to maximize these medications into the chest. And so the best way to do this is to watch a patient demonstrate their inhaler technique. They need to make sure that when they're breathing in the medication, it's a slow, steady, deep inhale. If they are breathing in too hard or too shallow, the medication is not going to work as well as it should. And so to show you proper technique of a metered dose inhaler, the patient should make sure that they shake up the inhaler well, do a good priming breath for their lungs. So have them take a breath in, exhale from the inhaler, and when they're ready to take that second breath, they can insert the inhaler and then take a slow, steady breath in, like this. They should hold their breath for as long as comfortable and possible, but at the minimum, they should count for 10 seconds and then exhale slowly. because the longer we can retain the medication in the lungs, the better that medication is going to work for the patient. Now let's go ahead and just see how it works with a holding chamber device. What a holding chamber is this is a prescription medical product that helps to minimize side effects with metered dose inhalers while preventing optimum inspiration with the inhaler. With this particular brand, what you're going to notice is it adds that little bit of extra space, but in addition to that, it has a one-way valve so that the patient doesn't accidentally lose medications when they take their inhaler. And with this particular model, if you notice, this top part has a flap. This can be very beneficial when administering this if a parent is administering this medication to a child. Because what will happen is when the child is inspiring or taking that air in, the flap drops and gives that visual representation that the child is inhaling the medication. And so to use a spacer with an inhaler, again, you want to shake up the inhaler, insert it in the spacer, take that nice priming breath, The spacer is a nice device that if a patient is taking the medication too forcefully or too quickly, it's going to give them an auditory signal that they need to slow their breathing down. So if I inhale too forcefully, the spacer device is going to whistle so that the next time that I would take my inhalation, I would know it needs to be that slower, steadier rate. So if you have a patient that has problems coordinating the inhaler with their breaths, and if you would ever see somebody demonstrate an inhaler technique like this, where they're losing medication off of the top of the inhaler, it means that they're actually breathing into the inhaler when they should be inspiring or taking that inhaler into the lungs. And so then that's why the use of a holding chamber would be very beneficial, especially for those patients. When you do have a holding chamber, you can use it with multiple types of metered dose inhalers. So you don't have to have a specific holding chamber for a metered dose inhaler. Typically within these products then, there will be specific cleaning instructions, which we'll actually refer to towards the end of this module. Let's go ahead and go through a few cases of spirometry to help you solidify your skills. So when you start looking at a spirometry report, the first thing that you should look at is to make sure that it's a good report. And so when we take a look at this one, we want to look at the number of efforts. And so you can see here that in this particular case, that there were 3 before medications and 3 after medications. And remember that when we talk about reproducible effort, you would usually have 3 before and at least 3 after. And we can look and see that there is 1, 2, 3 before medications and 1, 2, 3 after medications on the flow volume loop graph as well. So we know that this is a good measurement or a good report that we could use. We also don't see any artifacts, and so we can start our interpretation process. So right away, the first thing you should look at is look at your graphs. We'll look at the flow volume loop and the volume versus time curve. That will tell you graphically right away is there potential restriction, obstruction, or is the spirometry normal? And as we can see with this graphs, and we'll pull out one of the pre and one of the post. If I highlight for you here how that it's shaped, we can see that there's a concavity to the flow volume loop, which is very characteristic of obstruction. We can also see in our volume versus time curve, if this person was not demonstrating obstruction, you would see a nice quick rise and then leveling off. But here you see it takes a lot longer for them to get to that plateau or that leveling off period. So again, showing us that there is potential obstruction. So we see obstruction in our graphs, so let's see if there's obstruction when we look at the numbers. And so the first number, or the first category that we're going to look at is the forced vital capacity. And in this case, the patient's forced vital capacity is 73%. And if you recall, we want that less than 80%, so we would say that this is decreased. We look at the forced expiratory volume in 1 second, and in this case it's 58%, and we would like that greater than 80 to be considered normal. So in this case we would say that it's decreased. And then when we look at our ratio, and remember we always look at the patient's actual value, the patient's ratio in this case is 64%. So again, less than that 75 to 80%, so decreased. So everything here up to this point is telling us that we have obstructable lung disease. But we need to figure out, is the obstruction reversible? And so the way that we do that then is that we look again at the forced expiratory volume in 1 second, and we're going to look at the pre-value versus the post-value. So before and after we gave medications. And remember that in order for it to be reversible, they have to reverse by at least 12% and 200 mLs. So in order to determine reversibility, what we look at is the forced expiratory volume in 1 second. And if you recall, the person has to reverse by at least 12% and 200 mLs. And so in this particular case, when we look at the percent change, the patient reversed by 9%. And so then in this instance, they should have, in order for it to be clinically significant, they should have reversed by at least 12%. Okay. And so right there, we don't meet one of the criteria for reversibility. But let's go ahead and see if there was any changes in the volumes. And so if we look at the FEV1, we can see the pre-bronchodilator volume was 264, and this is always in liters, and we're looking for a milliliter change, so you just convert that to mLs to milliliters. And then if we look at the post, which is the 2890, what we're going to do is we're just going to subtract that, and so you get a change of 250 mLs in that instance. So they did change enough to meet the criteria for reversibility. So the 250 is definitely greater than 200 mLs. However, with the percent change being less than 12, we would say that this is not clinically significant reversible airflow obstruction. And so further testing would need to be done with this patient to determine, do they have asthma, do they have COPD, or is there another process that's going on with their lung disease?